a very important part of our daily activity, either in research or in the public health practice, because making a population diagnosis, for example, an epidemic, or to evaluate the impact of any sort of public health intervention has to be based on some sort of information. But despite this importance, I don't think that in general research and development on health information system is so highly valued, especially perhaps in the academic field. And there are, during the past 20 or 30 years, it has been relatively few ideas, few new tools developed in the practice and in research related to health information system.
I thought I'd just give you sort of an evolution of health information systems, sort of where we've been, where we're going, because we'll end up by actually having the beauty of having all of these things, the way we can put them together and actually have something that is not present now, but I think will be dynamically present in the future. And so I think this is an opportunity to be extremely excited about what's going to be happening. So let's go back to the beginning, which is really when we started trying to look at populations. Typically the route we've taken is to actually do population surveys. And you look back, we do that, we get patient-reported health status, and we get risk factors, and we can do that and get a representative sample of the population. And we developed a lot of methodology, sampling methodology to do that. So here you can take a look at the prevalence of cigarette smoking back in 1964, and you can see in 2006, we're really still doing the same thing. We're actually surveying snapshots of the population, getting an idea of what the risk factors are. And so here we see, for example, that prevalence of smoking varies an awful lot by country, and this surveys do allow, which are done annually or every 5 years, opportunities to compare yourself with other countries and look at really population health interventions you might have done and what impact that might have had. One of the issues with health surveys is that you're repeatedly doing these random sample snapshots of the population. And one of the difficulties with that is if you're seeing changes through time, you're kind of wondering, is that because of differences in the sample I've got, or is it really a trend going on in the population? So survey methodologists have increasingly started to use a subsample that they actually will follow in repeated surveys through time that allow you to look at trajectories truly within the same individual in a particular environment through time. And so here was an example of looking at changes in depression, and so increasing depression through time and a reduction in marital quality. And this was sort of a social science research question about really what is the impact of our new social environment essentially on health. So there are pros and cons. I mean, you have standardized methods of actually collecting information in a representative sample of the population, which is good, and you get sort of self-reported health status and risk factors. The downside is really, I think there's an increasing intolerance to the length of these surveys, to the time it takes people, and I think that you'll see greater and greater problems in getting a reasonable response rate to the surveys. And then on top of that, they're really quite expensive. And there tends to be long lag times between the time the survey is done and the time you actually have it available to you. So it really, from the point of view of real-time monitoring, is really not the tool which is, has great advantages. At the other end of the spectrum, that was snapshots of the population, we can look at really health system use. And in fact, the first things that people often do, because health systems tend to be hospital or hospital-centric, is to actually look at what's happening in the hospital sector. And typically how information is collected there is you have a hospitalization, there's a discharge summary. That discharge summary is abstracted by an archivist, trained archivist, and in a standardized format using either ICD-9 or ICD-10 and some classification for procedures, you actually have a standardized method of actually collecting information on what the hospitalizations are about. You probably know all about hospitalization data, but you probably also know that in a given 24-hour day, in fact, hospitalizations are relatively rare events. That if you look at the health system at large, is the hospitalizations represent a very small sector of that. Maybe 10% of healthcare utilization is in that sector. But the other piece of it is that that sector is very expensive. So it's about a third of all health budgets, and this, give or take, a few percentage points, are devoted to the acute care sector. So this is where people are spending their money, and so understanding what's coming in the door and what's going out of it is really a good thing. So, of course, the question is how good is the data that's abstracted? Now, it's a human abstracting it, which has been trained, so a human abstracting from paper. And so some things have very low error rates, and this was an early study done in this area. Principal diagnosis, for example, in age and sex. But when it comes to comorbidity, actually, the error rate goes up, and really there's a very poor understanding, using only the discharge summary, of the urgency of that admission, because you're really looking at the end of it, not at the whole course. The other phenomenon that happens is as you start paying hospitals rather than beds used, and you start paying by case mix, which one of the most common one is diagnostic-related groupings, is that you see upcoding going on, or you might say more accurate coding going on, meaning that people are really going after the comorbidities that will increase your case complexity, which increase the amount of money you make as a hospital. So this phenomenon was well documented in the US when they moved to diagnostic-related groupings, and you can expect to see it in any country that will probably be going down that pathway. So there are pros and cons. It really is a standardized way of capturing information in the highest cost utilization sector. It does represent a small percent of the services. Again, there are long lag times, and I think this is probably even unnecessary. It's expensive because you're using very highly qualified humans to do it, and there are, of course, these diagnostic coding issues as it relates to payment, and I think this theme will come back again and again. When things are related to payment, you see certain behavior going on, and you need to understand that as a public health person and as a researcher. So another area which has been exploited has been health insurance databases. And why is that interesting? Well, it's interesting because, unlike hospitalization, for most health systems, the health insurance databases pretty much cover all insured services. So it covers most of what happens in a health system, unless you have a large segment of the health system who is not insured, such as you have in the United States. But for places like Canada, it would cover, we have a single payer, it covers almost everything that's a central health service, and so we have a population snapshot if you start using administrative databases. If you go to other countries that have multiple insurers, if you actually can have data from all those insurers, you have the same benefits. So if we look at the pioneers in this area, actually they came from Canada, which surprised me, as although Nora Liu herself is an American, she came to Canada to exploit the single payer system databases, their population capture, and in fact she started doing variations in surgical rates, as did another fellow in Ontario. And then along came a very arrogant kind of pioneer who just said, I think I can use this in a very different way, and that was my chairman when I first started at McGill, Walter Spitzer, who said, I'm going to use it for pharmacoepidemiological research to look at adverse effects related to drugs. So really interesting. So any insurance database has really the following. It has something about the beneficiaries. So usually, ideally, it's actually by individual, not by family, because that creates certain issues. So their age, their sex, and something about where they live, which can actually help you figure out socioeconomic status. They have all the medical services are commonly insured in there, including who did it, what did they do, what was the diagnosis at the time, and how much did it cost. For many places, in fact, they also insure other things: dental service, orthopedic services, physiotherapy services, chiropractic services, and so it depends on what's in the basket. Medical services tend to always be there, but there are often other things. And then finally, prescriptions. What drugs did people get, how much did they get, and over what period of time? So really exciting, because you can actually link all those databases together, and you can actually start looking at what happened to people in that. And so I'll just give you a cook's tour of a few things that have been done here. So here's regional variation in volumes and costs in the US. And this is from the Dartmouth group, who was another pioneer in the area, basically using administrative databases to do this kind of work. If you look at, so that's really counting services. But if you want to go a little bit beyond that, you want to start using the diagnostic codes in those services. They're not usually paid by diagnostic codes, so watch out. So that was the whole thing. You can actually have nonsense in those diagnostic fields. So in looking at it for chronic disease, can we start monitoring chronic disease using these databases? And the answer is probably yes. High specificity, lower sensitivity. If a person's in and out all the time for, let's say, their hypertension or diabetes, you tend to do better than if it's something episodic like gout. So if you look at things that have been done with respect to that, so Ontario looked at, for example, the change in incidence, which was none, and change in prevalence of diabetes. So really what it is more diabetics living longer that need to be managed. And so this was useful in terms of health system planning. If you said, well, I really want to look at this for acute conditions, you know, for chronic conditions, you say, well, the person's coming back again and again, and I'll eventually figure out what they have. But what about for acute conditions? And so this was a graduate student at McGill who took this on saying, I wonder if I could use it to track influenza. And so you can see right at the bottom here, as in along the sensitivity column, you can see it's not very good. You know, you miss a lot. You know, the diagnostic code, you may come in with your hypertension problem, but you're really there for your flu, is that the flu doesn't really get documented. But when it does, it's accurate. But if you basket them all together and say upper respiratory infection, you do much better. So you're at about 50% sensitivity at that point. But what's interesting is actually it does have a reflection of what's happening in the population. So even with that lower sensitivity, which isn't capturing everything. So here the red lines are all of the hospitalizations for influenza, and the blue lines are all of the visits for influenza. So you can see they behave in exactly the same way. A big season going on in the wintertime, peaking in January, and something fairly lowest prevalence in the summer. And you see that year upon year upon year. So you actually have a mechanism of actually starting to track this. Maybe it may not be as sensitive as you would like, but it did allow, for example, a policy that was to vaccinate children 2 to 4 years of age in Massachusetts to be compared to not doing that in Quebec. And you can see that after that policy was instituted and implemented, that actually the health system use, meaning visits for influenza, were relatively the same in Montreal, but actually were lower in Boston. So kind of an exciting tool that allows you to start evaluating some public policy interventions. It's also been used to actually document injuries. So if you look at injuries that require repair, so soft tissue injuries and fractures, as you can see again, probably slightly higher sensitivity, especially if you combine the diagnostic code with a procedure code that says I repaired a hip fracture, for example. And you can use that to actually create maps of where are high rates of injury versus low. So you can see in the northern and Midwest US is that they have the highest rates of injuries. Similar mapping was done in southern Ontario, where you see what we call cottage country was an area of high rates of injury versus lower in the urban area. So this is fantastic work for planning and for anything you're wanting to monitor through time or monitor interventions as this kind of work. Another area of tremendous use has been in the area of prescription drug use, looking at both evaluating policies, use, and outcomes. The validity of this data is really very good because you're paying someone who just dispenses a medication for the drug and the strength. It tends to be problematic in the area of quantity and duration, mainly because pharmacists will sometimes split a prescription to actually get greater numbers of dispensing fees. So if you're counting prescriptions, you end up by actually finding that Quebec uses 4 times as many prescriptions as the rest of Canada, and it's not because they're on more drugs, it's just that their pharmacies are more lucrative. So what's really fascinating is now you can start creating these longitudinal histories. You start linking things together. So I'll give you an example. Here's a woman, 72 years of age, and she went on the weekend to a family medicine clinic for a urinary tract infection, and she picked up an antibiotic as a result of that. She then went the following week to her internist, where she was prescribed a series of medications for her atrial fibrillation and her diabetes and her hypertension. And then she went on to a rheumatologist, where she was seen for osteoarthritis and got a COX-2 inhibitor. There was an interaction between her antibiotic and her anticoagulant, and she had a hemorrhagic stroke. As a result of that, she was hospitalized for that, developed seizures during the hospital stay, was prescribed Dilantin in excessive doses. She actually then went home, fell down, broke her hip, likely due to side effects from the Dilantin, was back in hospital for repair, a hip fracture, and then went to long-term care. So you can actually create these longitudinal histories, and you can begin to look at, with fairly good, precise temporal information as to what's happening in a series of events for an individual. So in Quebec, we used this kind of approach to actually looking at what happened to people when a co-payment policy was put in place to increase the revenues made available for covering the non-insured. And you can see for essential drug use that, in fact, the policy that was introduced essentially lowered the number of drugs per day, meaning it produced a policy-induced non-compliance in the elderly population. Similar approach was taken in the United States, where one company actually lowered the co-payments for statins, and in fact, what resulted from that was a corresponding reduction in physician visits and hospitalizations for cardiovascular events compared to companies that had and maintained their co-payments. Here's the Walter Spitzer study, and this resulted from excessive number of deaths noted in New Zealand from this new drug phenodorol. He used, in this case, the Saskatchewan, which is a Midwest province database, to identify that asthma deaths and near deaths actually were because of this drug actually being prescribed in fairly excessive doses. And in fact, that was really the thing that actually increased the risk of death and near death from asthma, was the potency of this drug when prescribed in that fashion. Here's another investigator, essentially from Ontario, noting that as the prescription rates for a drug used for congestive heart failure went up, so did the number of hospitalizations for hyperkalemia go up. So again, you can start monitoring things that are happening in the population and monitoring adverse effects. So the good news is you often have a comprehensive picture of the population and services provided. And when you're in a single payer system, in fact, you have a complete population snapshot. The downside is that the diagnostic codes are not typically very sensitive, and they're not, but tend to be specific. And this is heavy data. It means it's a lot of data, and you actually need different skill sets. It's not like surveys where there's one line for patient. It could be one line or 5,000 services per patient per year. And so it requires a whole new set of skills to start managing this data. So here's where the good news is coming along. So administrative data, it's linked to payment. It has certain behaviors that, because it's linked to payment, some good, some not so good. But electronic health records are really interesting, because here we have detailed clinical capture of events that are going on. In North America, most computerization is happening in the hospital sector first and moving out to primary care. It's the reverse in Europe, where most computerization happened in primary care and is now moving into the hospital. But just to identify what's happening in the hospital is most of the what we call feeder systems, pharmacy, diagnostic imaging, lab, has always been computerized for some time. And now, in fact, there's the opportunity created, if you can actually link that together for the same individual, which is, this is the prototype here, is you can put it into a warehouse and start using that information very, for research and monitoring purposes. Here, the Reichenstreif, which is in Indiana, was one of the earliest regions, essentially, to set up computerization vastly through the region. And in fact, they've now been at it for 50 years, and they now use this system actually for picking up patients who could be enrolled in clinical trials. We could have also used a system like this. We had a big C. difficile outbreak in Canada and many hospitals, and it was actually not covered by public health. There was really no knowledge of what was happening until very late in the game, and these patients could have easily been identified using this kind of a mechanism of actually querying for certain problems, hospital-acquired infections, and so on. So there's some really exciting things happening, and depending upon where you are, you'll see this come sooner or later. So here's an example from Partners Group in Boston. They created a longitudinal medical record. They're using it for a whole bunch of purposes, including clinical care. But they created a research portal that would allow any physician or health professional in the institute to actually dig into what was happening in the population and actually identify cohorts of individuals. You want to follow all your diabetics or all your people with congestive heart failure, and you could actually look at the notes, and you could look at the diagnostic images for that individual. So incredibly rich data at your fingertips. So this is a most unusual situation, which in fact you'll see expanding and create all sorts of new opportunities. Veterans Administration, for example, which brought itself in the bottom of the leaderboard in healthcare to the top of the leaderboard within a space of 10 years, did that predominantly through computerization and a huge culture change in the Institute, which was enabled by information systems. But they've started to use this to assemble virtual cohorts. By virtual cohorts, I mean they had 360 different electronic medical record systems. They retrieved and created cohorts of HIV Hep C patients that they wanted to follow through time, and they created those cohorts by using their electronic health record system, standardizing the data at source, and then rolling it right up into a national resource. So these are exciting times, folks, because I think when you have hospital-based cohorts in particular, or comprehensive health systems, managed care systems that are digitized like this, like VA, the VA is, you have great opportunities to do some really interesting work that you couldn't do elsewhere. So here's the Veterans Administration looking at essentially cancer incidence by age group and so on. In Europe, of course, it's been primary care that has been computerized first, and the GPRD, which you may know, the General Practice Research Database, has been available for sale, for use for a whole variety of people around the world. It contains about 5 million people from the United Kingdom, and it was the database that was used over the whole scare about the measles, mumps, and rubella vaccine and its association with autism. So you can see here at the top is what kids were immunized, and you can see at the bottom what was the rate of autism documented over time, and you can see that there's absolutely nothing happening. It's the same level playing field for MMR and a change in trends. Fred, did you? Okay. He's making me edgy. So here's another one, attention deficit disorder. Ritalin use is increasing rapidly in populations. It's about 2 in 10 kids in the United States are on Ritalin, 1 in 100 in the UK, and you can identify where the peak is. It's little boys who are rambunctious, and it's usually around the ages of between 7 and 12, in fact, that they start being diagnosed and obviously then being treated, even though, and the disorder basically has actually been changing modestly through time. So advantages, disadvantages of electronic health records. This is point of care information, so it's really real time, can be generated, and actually can be used for monitoring, and that's exciting because that creates new opportunities to do things very differently. The downside is that clinical documentation is typically unstructured, and that's where all the rich data is, meaning that you're taking someone's handwritten notes and you're putting it into a Word document. That's basically what you've got oftentimes with electronic notes. And there's then a lack of standardization across systems. So let's move into the final hurrah, which is in real-time monitoring. I'm sure all of you are aware that big data mining is going on in many companies. So Google, Visa, Walmart basically are using their databases to profile you. They're using them to figure out what you're going to do next and what you'd like to do next. Can you imagine us doing something like that in healthcare? I think we should start imagining us doing something like that in healthcare, where we can provide patient-centered, very personalized information with you being a stratum of 2 or 3. There have been some embarrassing things, such as, emails being sent to target people who have a certain profile. You're buying a lot of baby things. Maybe you're having a baby. So emails being sent, and that was the one story that was sent to the dad by mistake, and he didn't know his daughter was pregnant. Anyway, long story on the Walmart front on that. But this is exciting times, and I hope Arnaud will pick up on what big data can do, because I think this is where we should be going in healthcare. So if we talk about leveraging rich data flow, so we're not just talking now about visit information, we're talking about like streaming information, like streaming data information. So here's something coming from monitors in the neonatal intensive care unit. It was smart analytics. By that we mean, in our old-fashioned way of epidemiology, talking about predictive modeling of what's going to happen next. And so this is used to identify kids that were at risk, who are crashing, because you're using streaming information, you're applying complex predictive algorithms, and you're using it to flag people who are in trouble. Here's another thing of soon to be a billionaire creating a very low technology. You put it under the bed, and it monitors heart rate and it monitors respirations and movement. They use predictive modeling again here to identify people at risk of crashing, and this can be put in every hospital bed and in every home for people who are actually maybe at risk. So they've really fascinating results coming out of this kind of a decision support. Increasingly, we're seeing what I'd call real-time texting by the clinical care team. They're doing this anyway on their iPhones. They're down in the surgical suite actually taking pictures of their surgery and tweeting it to their resident or to the attending. And now this is now being structured in a way that you're seeing a real-time flow of what's happening to someone. And because you're seeing real-time flow of information, that creates new opportunities for these predictive algorithms, smart analytics to take place that you can actually use to alert on things that are going wrong or going right. So this dynamic analysis, we tried using this with real-time feeds on a daily basis for prescriptions. We wanted to reduce the risk of falling. We actually took a very fancy predictive algorithm that actually identified non-modifiable characteristics. It added the information on modifiable characteristics and actually displayed this as a risk thermometer to people at the point of care at the time they're prescribing that particular drug or renewing the prescription for that drug to say, this is putting this person at risk. And in fact, if they actually want to change what they're doing right now, it provides instantaneous feedback on what is the consequence of changing that real time. And if you decide to add more, narcotics to this individual, how much greater is the risk going to be by doing that? So this is providing real-time feedback at the point of care based on fancy-dancy, complex algorithms that are developed in epidemiology and brought down to the point of care. So really exciting. And in fact, what's interesting about that particular trial is that the higher the risk the patient was at, the more likely you were effective in introducing an intervention like that. A similar approach was taken with asthma. In this case, you're tracking emergency visits and the use of rescue medication, because we know that the slope of increase of use of rescue medication is associated with near death or death from asthma. And so this was alerting someone that this is what this person is having. They're actually having an increase in the dose, in the number of times they're filling their fast-acting beta-agonists. And in fact, that was used to say, this is the treatment they're on, this is what you should be doing about it, in terms of increasing the use of inhaled steroids to abort this particular problem. And you can see what happened here is, for asthma, a small proportion of the population are producing most of the out-of-control events that lead to ER visits and hospitalizations. And it was in that subgroup, in fact, that this intervention was successful. And I'll end here with what I think is coming next, which is real-time population monitoring. So this is a Canadian, actually, who moved to Harvard, and he introduced something called Health Map. And what it does is it looks at news reports, and it looks at what's on the web around the world. And what it does then is it actually identifies outbreaks by essentially this web crawling that's going on. This was published in the New England Journal. It picked up essentially the H1N1 epidemic in Mexico 2 weeks before the CDC surveillance system picked it up. And so very exciting new methods of doing business in terms of population health surveillance. The Food and Drug Administration in the United States has now picked up on this, and in fact, they are doing something similar for adverse drug events. Then there's this, which is the social networks, and I'm sure that many of you are tweeting, blogging, and Facebooking, and this kind of information is now made available for, in this case, tracking influenza outbreaks. So here's an example of someone tweeting something about how awful they're feeling. The FDA is now using this to look at adverse drug effects, and it actually shows that it can pick up essentially flu outbreaks long before you would actually pick them up normally. So I think what we're moving towards is something that is far more dynamic in the way in which we use data. What the IUM has called the learning healthcare system, where essentially you're taking complex patients that we've never really known a whole lot about, and you're starting to learn on the fly about what works and what doesn't work. Mainly because those people are never involved in trials, and yet they really are driving the healthcare system. So I think what we need in the future health system is we need a tripartite leadership between policy, clinical leadership, and scientific leadership, because underneath the learning healthcare system is big data, analytics absolutely necessary to generate evidence that can be used on the fly real time. So it won't be just static that we've actually used in the past. I think we'll be doing real-time analysis and learning from that. So in summary, I think historical methods of system monitoring, surveys, cancer registries, chart abstraction will gradually start disappearing as we digitize healthcare. We will now have more comprehensive clinical data. It will demand new things. So it will create new opportunities for us to monitor populations. It will create better ways of doing predictive modeling, because you'll just have richer time-varying data on individuals. There'll be new opportunities for early detection interventions, some of which you're seeing already. And it will require new skill sets, because this is different data to use than what we're customized to. And finally, I think we've only seen the beginning for the mining of social media data, and I think that will create new opportunities, not just for monitoring things, but actually messaging out to that population to act in an interventionist way. So I think it's very, very exciting times, and I look forward to any questions or comments about this. Thank you so much.
Good morning, everyone. So my name is Arnaud Chiolero, and thank you, Fred, for the introductions. I think my talk will be complementary to what has presented Dr. Tamblyn's, and also something perhaps important about what said Fred about my CV, that I'm in the mix between research and surveillance activity that we are doing at the Observatory Valais on la Santé. And I try to use these data. Dr. Tamblyn has mentioned all these new data which are produced by now by these information systems, and we try to use this kind of data. And my presentations today will be trying to give a flavor of what is new with this data, what is not new. I will insist on some difficulties we have when we try to use this data, and I will try also to give some idea of how these data are changing surveillance activity. Of course, this is a great simplification of a complex issue, but I hope it will feed some point for discussions after my presentations. Let's begin with these slides. I would say that expectations from big data are huge. Really, big data is everywhere now, and expectations are enormous. And according to, for instance, the editor-in-chief, the former editor-in-chief of Wired magazines, he said that big data could change science radically, and this could be the end of theory. The idea behind that is that data speaks by themselves. So let's speak the data. Let's listen to the data. Others say that this is not only in science and not only in health science, but according to the author of these books, it could change. Big data will transform how we live, we work, and think. And this book is quite successful. So there is a big expectations from big data. And I think now that big data become inevitable in health science, and the presentations of Dr. Tamblyn has shown that we have big data everywhere. I think we can say that until recently, healthcare was a little bit behind other industries in the domains of information technology and the use of big data. Massive data are generated by healthcare and health science, which are quantitative data, qualitative data, or transactional data. And Dr. Tamblyn has shown all the domains in which you have data you can use related to health science. I think we can say that until recently, data were considered as a byproduct of healthcare, but perceptions are changing now, and I think that increasingly so, we realize that this is a real asset for healthcare and for science. Based on that big data, the hope with big data that it will bring new knowledge based on observational evidence. It could help to improve or design treatment algorithms using electronic monitoring, electronic medical records data with decisions based on real-time patients' data analysis. It could help translate personalized medicines into clinical practice. If you imagine you can link electronic medical records with, for example, genomics data or all omics data, the potentiality are huge with that. And it could, according to the author of this paper, improve safety, quality, or efficiency of care. Expectations are huge with big data. Also in the domain of epidemiology, in research, size could be the next big things in epidemiology. What is new? Let's try just to summarize 2 or 3 things of what is new with big data. I think there is a new wordings. We have to be accustomed to that. This is big data, massive data, data deluge, or open data, or data-intensive healthcare, which is using real-time data to improve the care of the patients, data mining, data analysts, or also perhaps you were used to giga or tera, but now we have to think in terms of petabyte, exabyte, or zettabyte, this huge data. I think also that with big data, some health-related data becomes really analyzable. It was probably not possible before. For example, genetic data, electronic medical records become analyzable now. Internet query, flu trends, for example, or patients generated by the patients itself, by the individuals itself, what we call all the phenomena of e-patients or the self-tracker, and more and more. I will just give two examples. The first one is the famous one of Google flu trends, and you probably have heard about that, but this is a tool which allows to identify a flu epidemic, and which is based on using some query when you put those a family of words in Google search tools. At the times, you can track the times of flu epidemic. What is interesting is that you can see, for example, here I've just shown the slides for Switzerland. You have almost a perfect match between the Google flu trends and the reports of the officials, reports of the surveillance activities. And what is interesting also with Google flu trends is that it can be more rapid to detect an epidemics, as is shown here when you compare the Google flu trends with the CDC reports for the flu epidemic. So this is really new with big data, and this is a big advancement. Another examples of what you could do here, just to show that this is not directly related to health, but I just found recently this map, and on these maps you have all individuals of the USA, which are shown by one dot. So here on that map you've got more than 300 million dots, and every dot is one individual in USA. In this map they have put, using the census data of the USA, they have shown where the white were, the black, the Asians, and the Hispanics. And if you go just a little bit further, here this is New York, and you see that so every dot is one individual. You've got here Central Park, this is Wall Street, so we've got Manhattan here. And here, for example, you see in red, this is Chinatown. So imagine you link this data with mortality data, with local health activities, healthcare activities. The potential for big data is huge, and also for surveillance activities. What is also new is that, and Dr. Tamblyn has mentioned that, this is heavy data, so we have to deal with new analytic methods, which is data-driven analysis, data mining. It could be, to some extent, the end of inferential statistics, maybe the end of p-value, and I think many of us will be very happy about that. And this is also big data in the world of descriptive statistics, and there is some say that we could face the end of causality, and all things are just correlations and predictions, and big data is also very interesting because we can make, we have to develop methods for discovery of hidden relationships and clusters. Okay, but is that really so fantastic? I think we are perhaps now in a peak of expectations with big data, and we should take care not to fall in some frustrations with big data. And here I showed just this slide, which is a slide showing how with new technology, what are the trends. We may be here now with big data, but we may face a little bit time of frustrations, and I will come to explain why we come to that. Actually, the question is that, are the big data too big to fail us? And I think it's possible. To have perhaps a short resume, simplifications of what is the issue with big data, is that most big data are relatively cheap. And in the sense, the cheap data, they are cheap to collect, so it's very good things. But the quality of the data is sometimes poor, and Dr. Tamblyn has mentioned this issue. We have to deal with that and how to deal with that. And either it's a poor quality or the quality is not documented. And this is a big issue when we want to use big data. I think what is not new with data overall and with big data, I would say more than ever, with big data. We have issue of measurement error, misclassifications. Dr. Tamblyn has mentioned the specificity, sensitivity of some diagnostic with some data. I think we have big issue of selection bias. With big data, you have tried to imagine what is your source populations, and sometimes it's quite difficult. I will give you examples because I use big data for a project now in one region. And of course, confounding, if you want to assess causal relationship, you have to account of confounding factors, and can be quite difficult with big data. Let's look now perhaps how it could, 2 or 3 ideas of how it could impact surveillance activity. Just to remember of the definitions of surveillance activity, it is the ongoing systematic collections, analysis, and interpretations of data, closely integrated with the timely disseminations of this data to those responsible for preventing and controlling disease and injuries. I would say that the definitions of surveillance still remain the same, and the goal is to provide information which is useful for decisions and actions in public health. I would say that surveillance is changing with big data. A big advantage that data are gathered more easily and more rapidly. We have new data, with access to a huge amount of new data, and I would say especially on health providers' activities. Also, we have the ability now to make link between data, so it is changing surveillance activities. I will just make details of what I see as the paradigm change in surveillance methods, and which can be addressed when we think about designed and organic data. Design data. So I would say the classical process in surveillance is that you identify the health problems, you define and collect data, a finite amount of data, and you analyze data to address the problems. One pro is that this is design data. They are tailored for your problems. So I mean that you have designed the tool to measure things, so you have information on their validity, on their reliability, and on the completeness or the lack of the completeness of this data. What is count? This is poor timeliness, limited representativeness, and high cost. I will take one example, cancer registry, which is a fantastic tool to assess the burden of cancer in one population. It's typically a classical tool in surveillance, and it's using design data. You have a cancer registry, and you have tailored your tools to assess that. You know the limitations of things, but it's expensive, but this is one example of classical methods in surveillance. With big data at the time of e-health, it is changing because you have whole types of data which are collected from multiple sources without sometimes knowing exactly what you will do with this data. So you analyze data to identify problems and to address problems. I would say that one big advantage is timeliness, representativeness, at least potentially, and the low cost for sure. What is problematic is organic data in the sense that they are not tailored for your problems, and you have an issue of quality. Either it's a poor quality or it is not well described, so you have a difficulty to judge the quality of this data. I will take one example. Examples, if you want to develop quality indicators of healthcare in hospitals, you use typically administrative data or data from the hospitals, and you have big issue about what it measures actually. And when you have to convince, for example, physicians that they can use that for their surveillance, you have a big job to do because they all say that this is bullshit data, so you cannot use them for that. So it's a big issue with that. And what I would say that we need to do more, lots of research about that, how to deal with that. I will just give some examples with electronic medical records. So Dr. Tamblyn has mentioned that electronic medical records is a source of massive amounts of data and very interesting. This is quantitative, qualitative, or transactionals. I give here the examples of where I'm working in Valais. So Valais is one canton in Switzerland, and we have one health information systems which link whole hospital of the canton of Valais. Currently, we have 10 hospital sites where we have data from all patients here. One big advantage is that the private activities, there is few private clinics in Valais, so we have data of all the patients of Valais about. So it's and Also, all the hospitals are using the same systems of health system informations. So it's a big advantage to do things. We try also to have data increasingly so in senior healthcare facilities and from ambulatory healthcare too, and we try to group that. Currently, only this part is functionals, but we use that for surveillance activities. And currently, we have a work going on, and we try to assess the prevalence of diabetes in Valais, trying to use data from the hospital for electronic medical records. So we have hospital data diagnostic code, we have data from the hospital from the laboratory, and pharmacy data, and we group all that all together, trying to assess the prevalence in the hospitals and trying to see if we can use these things to estimate, one way or another, the prevalence of diabetes in the populations. Data are quite easily available and analyzables, but issue we have to think about that. Diagnostic of diabetes in electronic medical records or in diagnostic codes, what is reliability, validity? It has been shown that it can be quite high, but in our setting, is it good or is it bad? We have to test that, we have to assess that. We have to think about the hospitalization risk in diabetic and non-diabetic patients, how the diabetic patients are at increased risk of hospitalization. So if you want to infer one way or another the prevalence in the populations, we have to account for that. What is the source populations? Who is coming at the hospitals? Is that only people from the Valais? People from other regions of Switzerland? We have lots of tourists in Valais, so we have to account of all that. I don't mean it's impossible, but it requires lots of thinking and lots about all that. And another point is that when we do that, are we doing surveillance or are we doing research? And I think this is something a little bit important, but I will not go too much into that. I just suggest you should perhaps read this paper, which addressed the issue of using those kind of data. Final notes before coming, so with electronic medical recorder, I think we have an issue of data misreporting and of lack of standardizations. We have to really account of that if you want to use that for surveillance activities. Final notes before coming to my conclusions. I think another big issue is that we have to think what is our research questions. And when I was at McGill, I had a course by Dr. Tamblyn, and which was how to the protocol. We had to define a protocol, a research protocol, before doing our research. And we spent hours and hours, and I think the first lessons was about what is our research questions. And I think it's still valid with big data, and more than ever. And big data fan thinks we can let the data speak, but I'm convinced that data-driven epidemiology with flexible data analysis and lack of pre-specified hypotheses can lead to research findings which are not true. And I think for surveillance, it's also this is more related to research, but also for surveillance activities. So my conclusions would be that big or cheap data do not speak by themselves more than small or expensive data. I think this is not the end of theory, and I think more than ever we need to know what is our research questions and why we are making surveillance. Thank you for your interest.
I am a social scientist, so I would like to ask a question concerning two developments that are maybe in the other direction and which are very important in social sciences. One is the inclusion in surveys, in panel data of biomarker. So to have really small samples monitored over time, but to include higher quality in terms of biomarkers. The second development is an even smaller data set, which is a twin registry. So a high concern, at least for social scientists, is how you can control for unobserved heterogeneity. And there is, of course, an impact of genetics in different behavioral stuff. So to develop a twin registry is another way to have small data, but very good to draw inference. What do you think about the inclusion of these two data sets in your big picture, which is impressive and very interesting?
My question is related on the first knowledge that information, whether it is, or the data, whether it is small or big, it's anyway a tool for or the kind of precondition to take the right decisions when it is in particular value added, as Professor Roy said in the group. So my question is whether this DRG is, as in your presentation, Robyn, you said that DRG-based data is more reliable rather than others, just the vertical data collecting information. But in developing countries' context, the DRGs are really expensive and not affordable. Whether in order to have this right source of information with good analysis to take a good decisions in these countries with this context, is the DRGs can be kind of dogma, or that they can change everything? Whether it is really necessary to invest the sources, limited sources for these kind of expensive systems. Thank you.
Because I think this issue of, having the platforms, and certainly other companies such as Google, Amazon, and so on have platforms, Microsoft have the platforms. Healthcare tends to have wanted to keep, for confidentiality reasons, its data within firewalls that are only that data. So and I'm not sure that's going to change an awful lot, so I'd be interested in a little bit more discussion on that perspective. Because do we actually want to invest in a complete separate system, which we have done, or take advantage of some of the methodology that's already been developed? Just on that front, though, I think that this issue of the end of theory and the end of science that Arnaud was talking about, I think the temporal relationships. I mean, I'm a trained epidemiologist, so I don't think we'd ever give up on the temporal relationships being right. There's too much reverse causality that we're fully aware of, that really I think the step that we can bring is actually that to the table. So I think it will have to go beyond correlational analysis, because otherwise we will have stupid findings and do stupid things. With respect to Luca's question about the registry, I actually, for time's sake, deleted a number of the slides related to registries. So what's interesting, I think, that is happening, so, and I'd say very, very comprehensive digitized systems that you see, let's say in Kaiser Permanente or in the VA. I think that the make my own registry to separately as a complete independent function from the healthcare system will be, I would say, a dying breed, because it's very expensive. We've actually just spent, I don't know, I think we're at 500 million in creating a longitudinal aging cohort. We've had also, cancer registries, and the idea was, we want a registry on diabetes, congestive heart failure, this, that, and the other thing. And it was way too expensive. It's highly customized, personalized data collection. And the worst thing in the world is that your cohorts start falling apart. You have to actually put a lot of effort into retaining them so you can follow them up long enough so that you can see some of the outcomes you want. So yes, you get it at entry, good data, and maybe you even have representative data because, in fact, you were very good at getting people to buy in and consent when sampled, so that you do have that. But it is very difficult. Everybody wants to create a Framingham cohort again and again and again, and I think it's extremely expensive. I think they become quite non-representative. One thing that I've seen that's really fantastic is that taking a cohort, so the cancer registry in Ontario, for example, because it does not have detailed information about what treatments did they get, what were the results of their imaging studies, and so on and so forth in that cohort, it would be too expensive to do it, to actually input all that data. Is what they did is they linked to the digitized data. They have consolidated cancer centers so that cancer treatment isn't everywhere and anywhere, but they create the pipes from those digitized data systems right into their registry. So they put, I would call it a hybrid cohort model, where they've actually got a cohort collecting some information that you wouldn't normally find in health record, like environmental exposures and some of the biomarkers. And then they feed it with all this other additional clinical information. So I think that's probably what we'll see as a way to go as an interim step, and then ultimately to what you probably are seeing in the VA is really my prediction for what will happen in the future. And then I think the final thing on DRGs, and then I'll wrap up, is increasingly, as you digitize healthcare, you're going to a modus operandi where you are coding at the source. So that's probably the best way to do it. So as you're starting to enter, the person has Guillain-Barré, it's actually bringing up a menu of items so that you actually can pick the one that you think is the appropriate one. And so you're coding, the person who's making the diagnosis is coding it. And that, I think, is superior because you're bypassing the archivist who is actually trying to interpret what you meant and what you thought. And if it's ambiguous, you can actually ask the person at the point of care, is this really what you meant? So that actually relieves the burden, in fact, of all this coding, which is very expensive. An even further step is natural language processing, where you're taking text data and you're parsing it, and you're then saying, I think this is what this is, and you can get the person at the point of care to verify, yes, that's what it is. And so they're starting to do that with people who are, for example, texting, they have an adverse drug event, is that they text them back, basically, and it can be done in a way that you don't know who they are, to actually, if this is what you're thinking, can you fill in this form for us and get an error plan point or something like that for that kind of thing. So people are being very creative about trying to get better data out of the system and of trying to bypass some of the more expensive human processes.
What do we want to do with this data? And this is just the things where we have to really think about that. The efforts should be done. The scale also you mentioned, we should be very large scales. I agree with you, and but this is the questions of what we should do about that. But the question from Lucas, and I think Tamblyn just mentioned the idea of hybrid cohort. I'm convinced that we should continue to do some, perhaps we have to think at which scale, but high quality survey with good phenotypes, I think it's very important. But what should be done is to make link with other data. I think it's what I think you mentioned when you mentioned hybrid cohort. I think that is the future, but making high quality survey to address some specific questions, I think is needed. Data from hospital will not respond to that. I think about that also, we didn't mention, but when we want to assess efficacy or efficiency of interventions of trials, people have in mind that we could use hospital data and or big data to assess the efficiency of care or whatever. I think for something is possible, but it will not replace pragmatic trials and those kind of things. And I recommend the readings by Ioannidis about that, where he mentioned the difficulty of, because for example, now we are dealing with small effects when we compare drugs, for example, and I'm not really convinced that big data will help us to solve that kind of issue. For adverse effects, for sure, but for the effect itself, we will need to do survey or clinical trials and those kind of things.
Before going on with the question in the room, I just wanted to address, to go further on a couple of things which have been said. One is, I think that one of the final, the final value of an information system is really what sort of decision making it improves.
I think that's a very good question. It's actually something that's kind of disturbed me a little bit, actually. As to, there's the capacity to do all of this. And I think where the most dramatic results have been is when you're bringing back that kind of information at the point of care to the clinical decision maker or to the patient decision maker. There you see results happen. You see a change in practice. You see a change in what the person's going to do. And you see a corresponding change in outcome if it matters, meaning if the process matters. Where there has been less work has been in the area of, I'm going to create a dashboard so that health management can actually track performance and compare performance. So we have a number of those, and And of course, there's the usual yelling and screaming that goes on when you've got someone at the bottom and you've got someone at the top, and the person at the bottom, the usual response is the data's crappy. That's the reason that this is going on. It has nothing to do with me. And in fact, I think that just bringing that information in a comparative benchmarking way to a health systems manager is probably, it triggers them to maybe think about it, but unless you can help them identify what in the process might be broken. So if you see, let's say we have a very, very high mortality rate in hospital A versus hospital B in relationship to this procedure, if you can't help hospital A figure out what's wrong, they will just bury that because it's just too much effort to try to get down to it. And I think what we haven't done very well in these sort of dashboards of performance indicators, like the OECD does and so on, is help dig down below the surface and say, well, what really is going on here? Why might those differences be present? Are they just random? And so I don't think that we've seen the end of the day yet. I don't think that we've actually got it right yet, even for health systems managers. When it comes to regulatory agencies for drugs, for example, and you see adverse effects, is that we've seen an appalling lack of response to an increased number of adverse event reports in relationship to drugs. And I wonder whether or not the managers, the regulators of our era are actually really trained to really respond to real-time decision-making data. I think that that will be a new set of decision skills. I think that maybe public health more so than others, because you're used to actually getting surveillance data and wanting to know whether that's a bit above background noise. But for certain health system managers, I think there's going to be a training issue there, and I think that we don't have it right yet in terms of the dashboard.
Thank you, Robyn. You have to comment on?
I think this is a complete response for Dr. Tamblyn. Perhaps just add some things. What I see, I don't have a clear examples of what it could bring, but what I see, and I think this is very important, that it's opened what is going on in healthcare activities. At least, for example, in Switzerland, until now, we didn't know what we were doing in hospitals, what we were doing in. We still don't know what we are doing in ambulatory care, and I think those things of big data and having access to this data is making an opening to that, and we can at least know a little bit of what is going on, and this is a big bring. But specifically, I think your response was complete.
As an epidemiologist, as I would define myself, I've been seeing in the past 10 years at least more people sitting on that data than actually exploiting or taking advantage or working and producing evidence. So my concern is that, that's also that issue that if you have more data, it's not just a methodological or philosophical. Ioannidis' papers, which I read with great interest, are very important, but there's also a matter of efficiency with what already exists. I don't want another Framingham for myself. Just to be clear. But the second point, because that's been an area of great interest for myself, is what about developing countries at inception? So what about the advantage that e-health can have in countries that are not covered at the time, that will have and are already having an amazing development in electronic resources that we can influence with a view and a vision in mind, with health at the very center of this explosion of electronic facilities. Thank you.
Thanks. I'm Mariana from Tanzania. This is really fascinating for me that almost now you can know everything about everyone. And but I learned here also that big data is not necessarily cheap, and most importantly, that does not necessarily remove the challenges of quality of data that you would see maybe with smaller data. So I'm wondering why is the push to go large with the same challenges of quality, while you would rather maybe use the same time-tested surveillance techniques and where you would have more control over the quality of your data?
The minimal essential data. With all these possibilities, and I think I can tell the colleague, there's a lot been done already. You don't have to ask what can we bring to so-called developing countries. There's a lot going on already. And we can also learn from the so-called developing countries on what we do. And this question of minimal essential data is a very important one. We don't want just big data. We want also to know what are the minimal essential data to answer a question. I think this is something which I didn't hear so much. We have the tendency that, particularly in surveillance, we collect all what is possible, all nonsense, and that is not used. And then we sink into the swamp of all these big data and not essential data. And I think it should be the claim to use big data also, and that would really help our questions we have, for instance, in resources poor settings, to really get at these minimal essential data and not just at the big data. And I think I would like that the developments are discussed in this way, because that's then a real contribution, as I feel, from the practical situation to public health and surveillance.
Seems to replace very simple tools which were extremely effective in terms of decision making. And I remember when I was a young doctor and studying in the UK, they had at this time this sort of wonderful intervention called confidential inquiry into maternal death, for example. For each maternal death, they sent in the hospital a sort of team without any sort of legal perspective, but just trying to understand what happened for these for this disaster. And the idea was at this time that the consequence of the management of the hospital, the clinical management of the cases were immediately changed. And to the best of my knowledge, these sort of exercises are not done anymore in the UK, or at least in most of the regions. This is a pity if they are taking these sort of arguments just not to do this very simple intervention. Robyn.
Well, you guys are really right hot on the big buttons here. I can see that. So I love the comment sitting on the data, actually. I can't remember who now made that comment, but because that's been a very interesting phenomenon. There is a lot of data out there, a tremendous amount of data, and in some respects we use maybe about 2% of it. So a couple of examples have come up about that issue. One was the Bristol cases, where in fact, a lot of kids were dying as a result of really incompetent surgery because it was low volume, and that wasn't picked up for a long time. And we had a similar case in Manitoba where these kids were having surgery, and in fact at this point everybody knew that the data was black and white, but no one looked at the data. And this is back to, I would say hospital management is more by anecdote than by any kind of information science behind it. So that's a bit of a cheap shot. But for example, I am in an institution which had a C. difficile outbreak. It went on for 8 months before anybody recognized that there was a C. difficile outbreak, and of a major, it had a case fatality rate of 10%. So it's really rather remarkable that we have a lot of data, but we're back to sort of the management. It's not, you're not used to using the data. What do I need to know? What questions can I answer? What do I need to be able to do to act on it? And I don't think that, you have to know what those questions are, and you set up the kind of monitoring systems with the data that's there so that those people can answer those questions. I think there's going to be a paradigm shift. There has to be a paradigm shift here, because I don't think that it's going to be acceptable to go on sitting on the data and kind of ignoring things that are already there. So for example, in Ontario, Healthy Care for All has now been introduced, and really the bottom line is the CEO basically has their salary reduced as a function of, their higher than expected or whatever readmission rates, and a variety of other indicators that say you are responsible. You're responsible for what goes on. And the first thing that happens when you say you're responsible for what goes on and the performance of your institution is they need data. They need information in order to do that. So I think there's going to be back to this paradigm shift. I think there'll have to be a paradigm shift, and whether it's going to be the accountable care organizations, we finance you as a function of your outcomes, at which point you have to look, because otherwise you won't be able to do well because you're being monitored and paid, or you're being financed on the basis of your outcomes. And that's probably a good thing for healthcare. We've been too, I think, laid back in terms of just say, oh, we'll just do the process. And if you say that 2 out of 10 admissions is going to be a major safety event, it may cause your death. And we're tolerant of that, and yet, we're intolerant of 1 in 1,000 problems with, you know, meat products or contamination or whatever. I mean, we've got a long way to go, I think, in terms of performance quality. Maybe I just, because I could rant on about that for a while, so I won't do that. I think for developing the old techniques, why not use the old techniques? And I think I think there is a wow about big data. There's something magical that's going to happen. I'm going to press a button and my life will be cured of any ailment I have. And I think that there is that issue. And I think you have to be careful about what you want. Very clearly, the cancer registries were not doing the job. They for sure weren't. They didn't track any of the results from labs. They didn't keep track of any of the medications they were on. They didn't keep track of any adherence post hoc. And that's heavy, heavy data. And if you really want to do a good job, you need to integrate that, and that's what's beginning to happen. And then finally, on the final note of developing countries, I don't know whether, half my life is spent actually planning funding programs for other people, and one of the areas that we're planning with the International Research Development Agency in Canada is using essentially the mobile health data in lower middle income countries, wrapping that up so that it can be used to create a more accountable healthcare system whereby you actually have information to sort of monitor performance in that healthcare system. So we're funding people who will actually design those tools to do just that. Because I think that's an area of opportunity, and it's an area that has not really been that well developed.
Thank you, Robyn. Arnaud.
Okay, I think these questions are very too much difficult for me, but I will try to make few comments about what we have heard. Perhaps about the notions of minimal essential data. I have no idea how we define minimal essential data. So I'm pretty sure that at least in our systems we have a bunch of data, too much data, we don't use them. And for example, where I'm working in Valais, we collect data. The system is in place, but I have to admit I am sitting on data 90% of the day, and because I don't use, I think 1% of this data, but it's difficult for me to address that. I think about what Professor Tanner about the translations. I think what is very important, this is what we are trying to do in Valais, is that the people who are using dealing with the data in the sense that who are collecting the data should be close to the ones who are making health decisions. And I think this is really what is very important. This is why we try to do in Valais. For example, regularly I have the public health officers or the office of the public health officer is asking me, could you tell me what is going on into the hospitals? Show me the data, press the buttons. It's like that. And we have to take time together to realize that it's not so simple, that data are complex, that there's a question of quality, and there is trainings. I have to train the public officer, and she has to train me about what she needs, and we have to have those kind of actions. So I think for translations, the proximity between the ones who are using data and the ones who are using data for decisions are keys.
It's apparent for me that we should better collaborate on data management somehow beyond our own labs, because we all do lots of R&D because we need it, because there's no really system learning that we can benefit from. It's pretty much empirical work from your lab, your own context and all that, and I agree that it's more or less satisfactory across. So I wonder how we could facilitate some more global collaboration on this. And I think what Professor Tanner suggested, for me, it would be essential information for system improvement. Because that's what it is. It's not necessarily minimal data. It might be quite data rich, but it's essential information that has to be derived from this data. And maybe we could start with some big dots. Ambulatory sensitive conditions that lead to hospitalization, avoidable mortality, maybe a few big dots, build logic models that would enable relationships to be established so that it can be taught to leaders and managers and action leaders. But maybe we could create algorithms that could be used in different places and build some collective capacity to do comparative analysis and support decision making at the global scale. And I think it's something like this might contribute to help us go out of our lab, really, and do something more significant at the global scale. I'm not aware of any movement in this in this direction globally, and I would like the panelists to comment on what's the action out there, who's leading it, and is there any collective, collaborative effort that's occurring that we should get involved with?
Two things. One, there are these international efforts. It's not that we go across that. I think this is very important that you know about this one, because it's what the Health Metrics Network does, plus what the in-depth, that is more southern oriented, but there are 45 demographic surveillance systems. That's a huge amount of data, and it's exactly what we try to do across different cultural, ecological settings to do that. You should have a look at it. It's in-depth. It's very simple to find. And you see that's where we try to get these efforts. Secondly, short, minimal essential data is for me also rich data, and how to do it. It is actually because we have too much collected in the past. Here is modeling a very good way to do that one. And in surveillance, modeling on what is minimally essential to capture, let's say, a disease transmission coming up or a new pocket of transmission, you could actually use that. And the databases are in these international networks. We would need modelers who do that. These are very clear questions. And we have also, for instance, all the enormous data that the Global Fund has collected in all the countries now with specific diseases, all with this hunter-gatherer thinking we could perfectly use to model and see what do we need as a sampling frame in collecting these indicators in time and space and how much. And this would be a beautiful and very useful project for modelers to really tackle that one. So there could be brigades of PhDs to be done.
Okay, I think it is an excellent conclusion. We can conclude here. Just a very last remark. I noted this year that on one of the buildings there was a very relevant sentence just around here. I don't know if it's on this part or the other, but it's written, verbum laudatur si factum sequatur, which means, approximately, because my English is not better than my Latin, which means the value of words is measured by their consequences in terms of facts. And I think it's quite quite appropriate for our problem here, and just to see if all this development in the health information system will really produce better decision and better management of the public health. Thank you for our speakers for the excellent. Thank you for you.